So we conclude our discussion of cervical cancer with the part 2, which is the actual invasive. From where we are coming from, we said that by this time we have moved from dysplasia, we have completed the full thickness, and now we have reached the basement membrane, and the cancer has become invasive. So now this is the actual cancer. That one was the malignant state, which was basically a period of dysplasia. Now, let's look at the clinical features, meaning the symptoms and signs, differential diagnosis, complications, investigations. We look at the fecal staging, and then the management. So now, when you look at the actual cervical cancer, the symptoms that we need to consider, first of all, is PV bleeding. Now, this PV bleeding is not a normal bleeding. I can divide it into postcoital. So every time the husband meets with the wife or the partner, they see blood. Be suspicious. What could this be? Number 2, it could be intermenstrual bleeding. You know, you expect your menses to be at the beginning of the month, every month, beginning of the month, but you have some bit of bleeding in between. It's not always cervical cancer, but think about it as a form of abnormal uterine bleeding, because all these have been exemplified by the palm coin classification in the AUB3 system. Next, post-menopausal bleeding. Again, that's not normal. Most of the women would come back to say, no, my menses have come back. This is a 60-year-old lady, 68. No, my menses came back last month. You have to be shocked. Why do you mean your menses have come back? So you need to know that you're not supposed to have bleeding in the postmenopausal period. So, regardless of the type of bleeding, you have to look out plus or minus symptoms of anemia. You can't just ask about bleeding. How many pads have you changed? What, and you end there. You want to see how serious the bleeding is by asking about symptoms of anemia, such as dizziness, headache, weakness, fainting, palpitations, etc., etc. So it's always a good conduct for whoever is taking a history to always ask associated symptoms of anemia. And not just the symptoms, but also whether they've decompensated into anemic by ventricular heart failure or indeed the acute kidney injury. Next symptom, which is very important to check for, is vaginal discharge. Now, there's something about this vaginal discharge. It is watery, blood stains, and foul smelling. So, if especially an old lady comes to you and they have such a discharge, and they've got postmenopausal bleeding, be very suspicious. Okay, but it's not always cervical cancer. We shall see when it comes to differential diagnosis. Next, constitutional symptoms. We know that this patient would complain of things like weight loss. They will complain of anorexia, which is loss of appetite, and night sweats, etc., etc. Again, we have to think this could be a malignant process. And also, don't forget that in further history, you are going to find that maybe there is history of immunosuppression. You are going to ask about the age of first sexual debut. Debut? That's debut. Oh. You know, as we learned in my local language, that's how I learned my secondary school. So, this age of sexual contact, and then what else? You might also find that this is in the sexual history. You might find that this is a person who has got maybe multiple sexual partners and so on and so forth. Because you can't just end on asking 3 symptoms. You have to go further in your history, the social history, the what, and then you find that, okay, maybe this is pointing to cervical cancer. Including whether they are diabetic or maybe they are on immunosuppressive treatment. What about signs? A sign is what you either elicit or you find on examination. For instance, you can say, no, on examination, the patient has abdominal pain. Pain is a symptom. The sign is what? Tenderness. And that's academic tenderness. Not where palpating somebody outside the general hospital. That is not academic. We're talking about academic tenderness. You check, no, in the right hypochondria. So let's not confuse symptoms and signs. Signs should be purely signs. The patient is complaining of pain. That's academic industry. You mean the patient can check their own conjunctiva. So you find that the patient can be cachexic. Know what cachexic is? The patient is wasted, has lost weight. What else? You need to look for signs of shock. Some of these people could have bled a lot vaginally and they are in shock, or indeed they are anemic. Other than that, we will find that, and this is what I want to concentrate on, you have to do a speculum exam. Colleagues, I get surprised when we don't do speculum exam on patients with suspected. That should be the first exam. You don't start by doing a digital, then you do a speculum afterwards. Start with a speculum, that's the standard. Even the times we used to do what was called EUA staging and biopsy, we were starting with the speculum first. Because your digital can distort your findings. You've poked through the lesion, it's bleeding, that's when you go and check. Okay, so you need first to see. So on speculum, what are you looking for? First of all, you find that the cervix might be eroded. I remember during our time when we were young doctors, we would find that time cervical cancer patients used to come with very advanced disease. And then there was no cancer disease. Not that I'm very old. There was no cancer disease hospital in Zambia. We used to check them outside the country. So we used to give up on them. It was like no more. That's when I even learned about morphine. You give them morphine syrup with some dactylos, and you even pray for them. So that was what we were doing. Imagine. No, when we opened the cervical, that cancer disease hospital, I saw a huge difference. Stage 4 patients. You see a stage 4 patient today. See that patient after 6 months. You won't believe it. Okay? And that's the power of chemoradiotherapy. Very powerful modality of treating this disease. And I equally had an opportunity to work at cancer disease hospital. So you can see, these are now people who are stable. They just come once in 3 months, once in 6 months from different parts of the country. Yet they had very advanced disease. So I'm trying to compare with the kind of cervixes you are seeing. You put a speculum, there's no cervix. All you are seeing is a hole leading into the uterus. But there's no cervix that has been eaten up by the cancer completely. So that is one of the signs. Or sometimes you might have what can I say? Okay, let me call it a growth. Now, these growths or lesions are of 2 types. They could be what is called exophytic, as if something is punching out, or endophytic. Endophytic means there is basically ulceration. Okay? So the cervix is not really eroded, but it has an ulcer, or it has got a growth which is punching out. So you can have different versions. Then the other thing you find is that there will be contact bleeding. The blades of the cascal speculum Once they make contact with the cervix, it will bleed. That explains the postcoital bleeding, because the penile shaft is making contact with the cervix. Now you can see in our discourse, I've not talked about pain. Pain is not a common symptom in cervical cancer. If you are going to have pain, lower abdominal pain in cervical cancer, it's advanced disease. It means the cancer has spread into the pelvic side walls. So we are talking about something close to stage 3, B and above. So if somebody has got pain and it doesn't really look like cancer, then start removing cancer from your list, unless you are really sure that this is advanced. Now, what about when you do a digital examination? One of the things you're interested in is the consistency of the cervix. So the cervix will be hard and it will be nodular. The cervix is neither hard or soft. Not so. It's neither hard. Okay, Dr. Tamara has done more English than me. I'll be coming for lectures. I didn't know that neither goes with the no. It's neither, no? Oh, yes. I remember they taught us. No sooner did he come than he left. So it's neither hard nor soft. So it is firm. When you hear people say firm, it's something which is not really hard, not soft. Almost like the consistency of the nose. Okay. But this one is a hard cervix, hard, and you can tell it's nodular. Then the other thing you are going to find is that there will be the characteristic discharge. Remember, that discharge, including the bleeding, will be seen when you do an exam. But more importantly, you need to check for what is called the parametria, and you also need to check for what are known as the pelvic side walls. Now, colleagues, this one takes some bit of practice, some bit of experience. And no wonder I always emphasize, when you're in labor ward, you're on call. You find a midwife who is admitting a patient. You find your senior colleague who is admitting a patient. Always be on standby with the surgical gloves. That's what you used to do when you were learning. If my teacher does a VE, even me, I go and ask for permission. Madam, I also would like permission to also confirm, imagine taking the board, to confirm what she has found. Okay? Because I want to see, if she tells me station is +2, I want to know how does a +2 feel like. This is a right occipital anterior position. So that's how you learn. You have to be near somebody, because you can't do it at different times. You do a VE, you write the notes to go. The other one says, no, let me do it afterwards. You need to do it so that I show you. Put your fingers like that, orient them like that. Have you felt? I was with you last time, right? Yes. When you first felt the left occipital anterior position, how you get the position. So even this, the parametria and the pelvic side wall examination, it takes a bit of experience, meaning you should have done quite a number of women with similar things. Parametria is basically the size of the uterus. Don't remember, the uterus starts with endometrium, then myometrium, and then the parametrium, which is basically the adnexia there. So if they are involved during bimanual exam, this is on bimanual, you can feel that this tumor has gone in the parametry, or it has not gone in the parametry. Pelvic side walls also, it means the cancer has really gone up to the bone. Again, it takes some bit of experience to tell this is not the normal vaginal canal, and these walls are linked to the pelvic side walls. But as you practice more and more, you can get there, because this will speak to the staging. Okay, then finally, you need to do a digital rectal exam. Very important. People will laugh at you, you are dealing with intestinal obstruction, you have never done a rectal exam. They're just saying, no, go for ultrasound, which you are supposed to do abdominal x-ray. So let us examine our patients. Let's just do the right thing. So on rectal exam, we want to see whether the rectal mucosa is it free or not? Has it been involved or not? But also, like us, what we like, not everyone, but me and I know some of my friends, we like doing what's called a vaginal rectal exam. Vaginal rectal exam. One finger goes in the vagina, the other one in the rectum. Then examine. In my opinion, that's the best way of determining, first of all, the nature of the tumor, and also this pelvic side walls. So you put your finger and examine simultaneously through the rectum and through the vagina. So it's called the rectovaginal exam. But see, for starters, I think these three are okay. Okay, so we are done with the clinical features. We go to differential diagnosis. What will look like cervical cancer when in fact it's not? Number one, colleagues, you need to know that there are certain types of cancers that can be very similar to cervical cancer. Top on the list is endometrial cancer. In fact, the number of endometrial cancers here also. I remember. And if you check all these ones we did, because most of them, in fact, we operated on all of them, they came with the diagnosis of cervical cancer, not endometrial. So you can see it's very similar, because even in endometrial, you can have PV bleeding, you can have PV discharge. So what will be the game changer is you doing an objective examination of the cervix. If the cervix appears to be normal, you even do some VIA there, there's no acetoid lesion. Then you do an ultrasound and they tell you that there is some fluid mixed with solid structures. That's endometrial cancer, and let's prevent otherwise. Okay, in that case, you need to proceed and manage as endometrial cancer. But that should be a topic for another day where we'll just talk about endometrial cancer. And then the number two is cervicitis. You know, if the cervix is inflamed, we know that the culprit for cervicitis in the context of PID is what? It's chlamydia trachomatis. And I don't like this because this is what damages most of our women's tubes. The PID, which is so bad on the tubes, is chlamydia. That's the same one which goes also to the liver, creating what problem? Fizz. But there's a name in between. Fizz. Who? Eh? Oh, it's called you. Oh, I didn't know. Yeah, you know me, I might not know these English names. Fizz-Houkatis syndrome. So cervicitis, because do you know that if the cervix is very inflamed, you can have some postcoital. So don't scare people. If somebody says no, whenever I meet with my partner, I see some blood. Then you even say, spot diagnosis, cervical cancer. You scare them. Why can't you just assess them properly and see this could just be PID? Okay. Then three, don't forget a cervical polyp. For those of us who we worked together with, we've seen again patients coming with the suspected cervical cancer, where they even do biopsies on the polyp. But you have some pedunculated distal through the cervix. The cervix remains behind, and then the mass bulges out. Okay. So it takes a careful examination, because this part, it will appear very ugly. You know, you put a speculum, there's this thing, it's even partially fungating, it's bleeding, so it will look like this is advanced cancer. But if you examine it properly, you can put your finger behind this, then you feel the rim of the cervix, which appears to be smooth. And we've had this. I think the last case in point is the operation we did not so, where we opened and removed abdominal. But you have to be very careful, because imagine you miss a surgical problem and take to cancer the hospital, you know, for chemo. So you have to be very careful. So cervical polyp or a pedunculated submucosal fibroid, which has undergone some changes, can be suspicious. Number four, what else can it look like It could just be other causes of abnormal uterine bleeding, like metorrhagia or intermittent bleeding. Somebody just has some menstrual problem, but then this bleeding, it happens during sexual one, you can easily mix them up. So let's always think of differentials all the time. What else can it be? Looking like cervical cancer when in fact it's not. No wonder I've seen even some of the reports that we get, what do they come out? Cervicitis. On the same leaf. Whatever. Chronic cervicitis. Because it means that what they were suspicious to be, no, this could be cancer, let's get a biopsy on. It could just be cervicitis. No wonder it's not uncommon to find most of our screening nurses prescribing antibiotics. Because they know that this could just be some upper genital tract infection. You just give some medications and it goes. Okay, differential diagnosis done. Let's go to complication. So let us not also just be giving people antibiotics. Let's have evidence. If there is cervical excitation, there is a history suggestive of PIP, I think I can give. I'm not making it routine. And let's not give doxycycline to pregnant women or indeed to those who are breastfeeding. You know what it can do. Last time I was asking, which antibiotic causes great baby syndrome? Cervical. What about blue man syndrome? Your homework. Blue man and red man. Whoever seen a blue person and a red person, they are coming. There's also another antibiotic which causes, a drug which causes a black tongue. That would be good for, why can't we have a quiz? General surgery, this is Obzan guy. Then we interchange. The obstetrician prepares surgical patient. The surgeon prepares obstetric patient. So differential diagnosis, always, please, let's not label all patients to have malignance when we are not sure. Now, let's go to complications. Now, the complications I can tell you, there are very few in cervical cancer. The first complication is anemia due to bleeding, and we know that anemia will lead to shock. Anemia lead to shock. Okay. Anemia will lead to biventricular heart failure and the acute kidney injury due to pulmonary hypovolemia. We are talking about hypovolemic shock. What else? We know that this cancer, as you shall see later, can go for the ureters. So it will lead to postrenal AKI, or what is called obstructive uropathy. Very dangerous. For me, this is the most feared complication of cervical cancer. For me, that's the one I'm scared of most. It's not even about bleeding, it's not about anything else. It's this one. Because prognosis automatically becomes poor. Then the other one is the fistula formation. You know that this cancer can go anteriorly and lead to BVF, or go posteriorly and lead to IRPF. Then also don't forget sexual dysfunction. I don't think she will be able to have her normal sexual life once she has all these things happening to her. And also don't forget distant metastasis. The cancer just spreads everywhere. So think of these complications every time you are looking at the patient with cervical cancer. Investigations. Number one, we can do a simple full blood count. Number two, RBS. Number three, HIV test. Number four, we need to think of checking for the kidneys. So we need to check for serum creatinine and urea. Number 5, we need imaging. So we need to do abdominal, pelvic, ultrasound scan. And we are equally interested in two things. We are interested in to rule out what is called hydronephrosis. And we are also trying to rule out pelvic plus abdominal lymph nodes enlargement. These are the two reasons why I want an abdominal, a good ultrasound in cervical cancer. Number 6, we can consider what is called IVP. Does anyone know what IVP stands for? Intravenous pyrography. So intravenous pyrography is a special X-ray, it's a contrast X-ray where you put ultravis through a cannula, like the way you do it when you are going for CT scan. Then you do X-rays using a fluoroscope machine. So that is one of the techniques we use to look at the collecting system from the calyces, the renal pelvis, going down towards the bladder. And 7, but as you know, contrast studies, you need to know that the kidney function is okay, because we don't want to introduce ultravis in a patient who has compromised kidney function, because how will that contrast leave the body? But if you want, you can tally it with the hemodialysis, or I've seen some people using HMG-CoA synthase inhibitors. We have a physician, they will tell us an example. Finally, CT scan or MRI. But most importantly, the gold standard will remain histopathology, meaning you do a biopsy. And what type of biopsy do we prefer? It's a punch biopsy. You've seen how a punch forceps looks like? How many of you have seen a punch forceps? A proper punch. You've seen it? So you show one of your colleagues how it looks like and how it is designed. Because we've got different types of biopsies, the toe cuts, the wedge, the what, I don't know for surgeons what they use. But we need to, us in gyne, we normally use punch biopsies. No, for cervical cancer. But for vulval, we have other types of biopsies. So, basically, these are the investigations we need to consider when we have a patient with cervical cancer. Let's go to figure staging. Very important, extremely important part of my lecture, which is the second last. Now, colleagues, don't forget that the uterus is like this. Then we have the cervix. Then we have the vagina at that time. Okay, you can go to Africa on the side of an African test. Then don't forget you've got kidneys here. Kidneys are also coming this way, sending the ureter like that, coming somewhere in the region of the bladder. So now, how the cancer behaves is that it will start from the cervix. That is stage 1. Then from the cervix, what will it do? The cancer will, which card can I use? The cancer will move now up here towards this side. And don't forget, as it is going up, it will also hit into the parametria. Have you seen that? It can just follow the vaginal wall, or it can go into the parametria. That is somewhere around stage 2. Then it will move from there and move somewhere here, coming down. Now it can hit the ureter or not, and that will be somewhere stage 3. Then it will move out of what is called the true pelvis, and that will be stage 4. So if I was to put it in visual sense, it would be something like that. Now don't forget that when it is in stage 3, it can equally go more lateral into the what is called the pelvic side wall. And in the same stage 3, it can go inside the pelvis and hit into what are called the lymph nodes. So that is stage 3. So in that case, how do we stage cervical cancer? Sometimes we used to start with what was called stage 0. Stage 0 was referring to CIN3, which was called carcinoma in situ. We don't talk about stage 0 anymore. Then we go to stage 1. So in stage 1, and we use Roman numerals. Roman numeral number 1. We say that the cancer has extended, is confined to the cervix. But there will be something that I will add. I will put micro, or macro. But this has been removed in the latest one. Then number 2. So you create a big space. If you are writing, you create a big space here, because there will be something I'll write here. Then here, the tumor has extended to the upper 2/3 of the vagina. But I'll write something, plus or minus parametrial involvement. In stage 3, the tumor has extended to the lower 1/3 of the vagina. Again, I'll write plus or minus pelvic side wall involvement, plus or minus pelvic or abdominal lymph nodes involvement. And last stage is 4. Tumor has extended beyond the true pelvis. And then we'll conclude this one by saying plus or minus distant metastasis. But that is easy. So it's not difficult. If we were to take this approach, you take it broadly first. Not where you just memorize one big one word. Look at it, because it's following that diagram according to what I'm saying. Now, if we were to now narrow down, a long time ago what we were saying was that if the cancer is confined to the cervix, then we shall call this, we shall call this 1A. Again, A is the capital letter. And then macro is 1B. Micro means it will be in millimeters. These are small lesions where you need to use a microscope. But 1B is a big, it's like you just put a speculum, you can see the exact suspicious lesion. That is 1B. Macro with your eyes, micro with that. Now, again under 1A, there is 1A1 and 1A2. Now it has changed a bit because initially we were even including width. There's no width anymore. We're just using depth of invasion. So this is depth of invasion. Okay? So if we say 0 to 3 millimeters, then this would be 3 to 5 millimeters. How deep is the lesion? No wonder you see you need very, for those of you who want to do pathology. Have you seen that when you take a specimen to the biopsy, does it go straight to the pathologist? There's those people who do the first part. They do it called grossing. So they will measure the diameters, they will measure the weight, and things like that. Very important part of the examination. And I've observed that most clinicians, and I'm not even exaggerating, they don't even read the main text. They just say, the histopathology results have come out, it's written squamous cell carcinoma. What about those things they wrote there? Were they just for decoration? You're supposed to read. And I remember at some point I argued with the pathologist to say that what is written here is not pointing to a diagnosis. The findings here is of a different tumor and is not correlating with what you've written here. I think you wrote placental cytoplastic tumor, but the microscopic description was of a choriocarcinoma. So you need to read and see how they came up with the final diagnosis. So please do that. So this is the depth of invasion. What about at 1B? So at 1B, initially we were just using width, like the size of the lesion. But now it seems we also need the millimeters. So in 1B, we are saying all depth greater than 5 millimeters. All depths are greater than 5 millimeters. The lesion, how much it has invaded. Number 2, this 1B will have 1B1, 1B2, sorry, it's not a 1B1, 1B2, and 1B3. So now here we are looking at how the size of the lesion. If the lesion is between 0 to 4 centimeters, that's 1B1. Sorry, not 0 to 4, 0 to 2 centimeters. Then between 2 to 4 centimeters, that's 1B, and greater than 4 centimeters, that's 1B3. Hope it's clear. Because it's macroscopic, so now we are seeing this lesion, does it look like 0 to 2, 2 to 4, or more than 4? So sometimes we would nickname a 1B3 as a bulky B. Somebody tells you, I've got a cervical cancer patient who has got a bulky B. 1B, it means it's a 1B3. That's a big thing, but it's confined to the cervix. It hasn't gone into the vagina. Then we go to this one, which is in stage 2. Now, here we have 2A and 2B. Do you know what is in 2A? 2A, no parametrial involvement. So you can see that the cancer has gone to the upper part, but it doesn't go into the parametria. So with a good speculum, you can tell this lesion is going into the vagina, but when you do a bimanual, there is no involvement of the size of the uterus. But in this one, now this again 2A has got what is called 2A1 and 2A2. 2A1, it means you've got a lesion which is 0 to 4 centimeters. And here you've got more than 4 centimeters. So it's just the size of the lesion, also just like that. 2A1 and 2A2. Then we go to 2B. 2B, there is obvious, in fact you even use the term obvious, parametrial involvement. We are making progress, we go to stage 3. Here we've said the tumor is extended to the lower 1/3 of the vagina, plus or minus pelvic side wall. So it means in 3A, no pelvic side wall involvement. In 3B, there is pelvic side wall involvement, as noted by two things: non-functioning kidney or hydronephrosis. Now you see why serum creatinine becomes important here, and why the scan or IVP becomes important. Because now we are going beyond clinical palpation, we are now using imaging. And now they have introduced another one, which is 3C. 3C is where there is lymph nodes involvement. Remember, we talked about those lymph nodes, pelvic and abdominal also. So if they are pelvic, then it is 3C1. If they are para-aortic, then that is 3C2. So there are two types of lymph nodes. There are pelvic lymph nodes, like those which are very close to the cervix. Good example are the paracervical, obturator, and the iliac, pre and post bifurcation. So those type of lymph nodes are pelvic, they are within the pelvic cavity. That becomes 3C1. But if they go higher and they reach near the aorta there, then those are para-aortic, that becomes 3C2. No wonder even your sonographer, don't just say CT scan and you end there. There's so much to talk about in the body. You have to be specific. Put a star, look for para-aortic lymph nodes, look for this, so that they pay particular attention to what you are looking for. Then we go finally to stage 4. So 4, there's just 4A and 4B. 4A, it means that the cancer has gone to adjacent organs. What do we mean adjacent organs? It can be the bladder or the rectum. So OVVF and IRVF are stage 4A. And in 4B, as seen in most cancers, it's distant metastasis. It has gone to the brain, to the lungs, to everywhere. And that's the end of the staging. So now you see, if a patient comes with AKI, hydronephrosis, they'll come with features of uremia. They'll always be dozing, always sleeping, vomiting, itchiness, some coagulopathy, intestinal obstruction, meaning some ileus. They'll have some, remember, uremic pericarditis. Like uremia is taking the patient. It's like slow anesthesia. Automatically, even before you touch that patient, you can be suspicious. This is already at 3B. But because you can't tell with surety the stage, what do you normally write? We always say at least 3B. Because it can be 3B or more. But at least you always give the minimum, at least 3B, meaning 3B or above. That's how the language you use. Or this could be at least 3C1, at least 4A. So, okay. I'm happy we've talked about staging. We conclude with management. Last. So let me wrap this side. I don't want to disturb the staging there. So somebody can get a picture of that staging. If you want to, or if you've copied, you shall see that management very much depends on the stage. You miss the stage, you mismanage the patient. So management for cervical cancer depends on two things. Depends on number one, the stage. Number two, What else do you think it depends on? Stage? Okay, to some extent, it's the histological type, but it mostly depends on the stage. This is how it differs a lot with ovarian cancer. In ovarian cancer, management depends on the histological type. So even as examiners, we will know that for ovarian cancer, my student just has to know the histological types, even if you might not like them. Serous, mucinous, transitional cell, Brina, whether it is under the sex cord stromal, is it a granulosa cell tumor, is it a sarcoma, fibroma, or are we dealing with dysgeminoma, are we dealing with teratomas, are we looking at endodermal sinus tumors or yolk sac, or are we dealing with non-gestational or polyembryomas? So, in your memory, remove some of those like names of artists and their birthdays, replace them with the histological types of ovarian cancer. That's more academic. To create some space. But I know you can, when the village has 10 terabytes memory. So, but here, because look at the difference. For ovarian cancer, our staging is surgical. It's when you open, that's when you stage. Endometrial cancer, the staging is surgical. So staging comes last. But in cervical cancer, the staging is outside, it's clinical. That's the difference. No wonder we really want you to know the staging. I keep emphasizing on the staging. You can't just say impression cervical cancer. No. You have to tell me. Cervical cancer, squamous cell, moderately differentiated, at least staged at 2B. You see? That completes the equation because I even know the direction which the management will go. Okay, now, what do we mean by stage? If we have got stage 1, and here I'll use the same diagram to demonstrate. If you have something like, let me start with stage 0. You've seen the stage 0 here? That's CIN3. Colleagues, if you do a cervical cancer screen and it comes out as CIN3, you do a leap. What? Most likely for you to reach CIN3, the whole thing is VIA positive, more than 75%. You take to the lab, results come out as CIN. You come after 3 months, you do another screen, again VIA positive. You get a leap again for the second time. It goes to the lab and what do they find? CIN3. It means you've had 2 leaps, 2 CIN3. What are we going to call that? Persistent CIN3. And persistent CIN3 equals a total abdominal hysterectomy. But in the eyes of a gyne oncologist, a total abdominal hysterectomy, which I've seen people doing for fibroids, for what, is known as a simple hysterectomy. I don't know if it's simple, but it's simple hysterectomy or make 0 operation, extrafacial. That's the only indication for doing a TAR in the context of cervical issue. Never do a TAR, a normal TAR, on a cervical cancer. Patient will come back without recurrence and you will just help the patient go down quickly. Okay? So that's one. Now, some of these small lesions, like these ones, let me just mention like these. These ones, if you want, you can do what is called, what do we call an operation where you just remove the cervix? Amputate the cervix. Surprise me. Starts with trachelectomy. You can do trachelectomy or you can do what is called the cone biopsy, conization. So if this is the cervix, you can cut the cervix like that, remove this part completely. So that is conization or trachelectomy, just remove the cervix completely. Then later whether you work with the sacrilege or what, I don't know. But those are for those small millimeter kind of lesions. Then, for reaching up to here, this one, here you need what is called the Wathems hysterectomy. It's a form of radical hysterectomy. But again, it's not Wathems, I think it's Vathems if you've been to Germany. He has been to Germany, the statistics. He told me he's been to USA and Germany. Yeah, Vathems, okay, Wathems. Hysterectomy. So this hysterectomy, the way it is done, is totally different from the way we do a normal hysterectomy. Maybe in 1 minute I describe the differences. If this is the uterus and this is like that, this form of hysterectomy, what it does is that you've seen that most of these hysterectomies we start with the round ligament. You cut there, round ligament there, you go here, you cut. You go for the carcinoma uterine Z, you go for the cardinals. So it's like the operation is as close to the uterus as possible because you are removing the uterus, which has a problem of fibroids and so on. But in a radical hysterectomy, what you want to do is come up with this whole structure out, up to the upper two thirds of the vagina out. So let me say all this, including the things which are in the sides. Now, for you to do such an operation, you need to be mindful of what? Of 3 structures: the bladder, the rectum, the ureters. This should be out of your way, so that anything in between, out. No wonder it's called the radical hysterectomy. So on average, this operation takes about 6 hours, maybe 6 to 8 hours. Secondly, this operation also has got levels. So there's make 1, make 2, make 3. Depending on how lateral you go away from the uterus. Because you know that this cancer is going to go around. Then the other thing that you're going to do is you need to remove these lymph nodes. Now these lymph nodes, you won't see them when you open. They are in the retroperitoneal space. So this operation is done in the retroperitoneal space, not in the intraperitoneal space. And Dr. Tamara is an expert. She's the one who showed me first time where the intraperitoneal space is. Okay, so one of the things you are going to find is that when you start the operation, you know where you are cutting the round ligament, as we cut much lower, almost at its root. Then we open the intraperitoneal space. Then part of the things that we're going to do is detach off the ureter away from being close to the uterus. So it's called the roofing of the ureter. Move it out of the way, all the way until where it enters the bladder. Yes, and after you do that, that's when now you go and start detaching those structures all the way to the rectal and bladder pillars. And when you remove the, okay, in conclusion, when you remove the uterus, do you know how it will look like? It will look like this. It will look like this, together with the cervix. Then there will be a bit of vagina flap. So the vagina will also come out. It should be seen. So you won't see the cervix. The cervix will be covered. The cervix is like where this top is, and then you come out with a bit of vagina as well around it. It's called the vaginal cup. We did an operation of that date, and we even showed you. And then all these structures, the parametria will also come out together with maybe the ovaries and then the lymph nodes. So that's called the radical hysterectomy. Now, anything above 1B3, of course, depending on the experience, there are some surgeons who can go up to here to go for Wathems. But really, it has to be more radical in that case, maybe up to make 3. But I would generally say, from here, going down up to the end, it's the chemoradiotherapy. Now, what do we mean by chemoradiotherapy? Which chemotherapeutic agents do we use? We use cisplatin. Okay? And then, how many cycles? What is the dose? I can leave it up to you. I don't want to take you so much into gynecology. But at the same time, with the radiotherapy, we use usually iridium or cesium. You know, those are the radioactive sources. And you have two options. Either you introduce the radiation into the vagina, and that form of radiation is known as brachytherapy. And we use maybe about 80 grains. Okay, the dose of radiation is in grains, 80 GY, but that's a high dose. So you irradiate. And one of the complications of radiotherapy is that it will cause vaginal stenosis. So you might find that the vagina starts becoming small and small. So what do? You need to put something in there to try to keep the vagina open for sexual function. But of course, the bleeding will stop, the discharge will stop, somebody will get back, especially once they get used radiotherapy. We rarely do external beam radiation. The other option is to radiate from outside. But again, for you to radiate from outside and not damage the other structures, you need to sit around like this together with a physicist. Somebody who's never done medicine but has done physics. And also you need those other people who do what is called simulation. And you sit in a meeting. Those are one of the best meetings I enjoyed. In a meeting with a physicist, radiologist, pathologist, oncologist, both clinical oncologists, and those people give radiation. So you are discussing this patient, including you people who are midwives. And you are all discussing over the same patient, including the palliative nurses and also the social welfare, the pharmacist, and so on. And I keep saying this is how we should be doing things. You've got a patient, you sit around the table and discuss. Okay, so basically that is the end of this. Chemoradiotherapy is usually the way to go. As we know, chemoradiotherapy has got side effects, losing your hair, losing your taste, mucositis, and so on. Finally, in the worst case scenario, you think of palliative care. Palliative care, we are worried about 4 things. 1, bleeding, anemia. So if they lose blood, you transfuse or give them Martinez. Number 2, anorexia. I'm told most of it helps, I don't know. Number 3, analgesia. Give them adequate analgesia, and usually we are using tramadol or morphine. But you know that morphine causes constipation, and normally we add lactulose to it. Or step-ladder analgesia. Number 4, you are just worried about the psychological aspect. This person knows about a terminal disease, I will never heal, so you need that psychological care and counseling and so on. Yes, you can discharge them on a catheter, you can discharge them on a nasogastric tube, you can give them an antiemetic. So think of those other aspects of your management other than this. I think with those, I rest my case on this very deep, long topic, but we hope we have dissected this. Thank you.